It's a real pleasure to welcome Dr. Tom Foley. Hi, Tom. You're very welcome to QPS TalkTime. Tom is a consultant child and adolescent psychiatrist in Donegal, but he also holds qualifications in software engineering and economics and in public policy. Tom was, until recently, the Principal Investigator on the Health Foundation funded Learning Healthcare project at Newcastle University, and he's done a lot of work in learning health systems. It's remarkable, people who work within our health service in Ireland and the expertise that people have. It's been a real pleasure to connect with Tom and listen to some of his work. And I think he's keen to share with us the ideas, and in particular today, I suppose, how it might be applicable to the Irish healthcare system. So, Tom, you're very welcome.
Thanks, John. It's an absolute pleasure to be here talking to such a great audience interested in quality improvement in Ireland. And I think it's a great time to be talking about learning health systems in Ireland as well, because we have issues with quality in healthcare in Ireland, and I'm a CAMS consultant, and so you don't need to tell me about some of the issues that we've seen with quality, particularly in our area of the health service. But also, there's such a vibrant community here involved in improving quality, and such a lot of work that has been going on in recent years in the development of QPS and the Q community, and lots of other things that have been going on. And at the same time, I think starting to see some really significant investment in the kind of IT infrastructure and in informatics and clinical informatics. We see providers who are starting to digitize, starting to bring in electronic record systems. We see the integrated community case management system coming through procurement at the moment. And I think the learning health system concept offers an opportunity to bring these two developments together. And hopefully I'll be able to convince you of that as we go through today. And even if it's not something that you've been familiar with previously, it has its roots in the same things that you're talking about month in, month out. And it was interesting listening to Suzette Woodward talking about safe care last month, and particularly when she talked about the history of the patient safety movement going back to the early 2000s. And that's actually exactly the same roots that are shared with the learning health system community. Back in the US in 2001, there was the kind of landmark, the landmark publication, Crossing the Quality Chasm, by the Institute of Medicine. And there were similar reports in the UK and in Europe and around the world. And basically what they pointed out was, how can it be that we have so much investment in healthcare, so much new technology, so many new research findings, and yet we still struggle to improve quality and safety in healthcare. And I think we still struggle with those questions. And I think the findings that came out of that report and the reports that came after it were really relevant. And ultimately, the Institute of Medicine, which is now known as the National Academy of Medicine in the US, they published a series of reports on this through the early noughties. And in 2007, they published their first report as a solution to this, launching the concept of the learning health system. And so that's kind of where it started.
So you're going to run through just kind of some slides, really just to really introduce the concept of a learning health system now, and then we might have a chat then afterwards. I see some good feedback here kind of in the chat. So, lots of people kind of agreeing certainly with the statement that data is needed to save lives, and many people have seen it in various kind of areas of the health service, like infection control, or and the famous maybe misquote, if you can't measure it, you can't change it, from Lord Kelvin. So we can chat about all those things in a few minutes.
Yeah, so I'll talk a little bit, John, about some of those things as we go through, and maybe challenge that statement. Okay, here we go. And as John says, I'm going to try and run through this as quickly as possible, because the discussion is always the most interesting. But really, the most simple definition of a learning health system is a health system that learns from every patient who's treated. And the key thing to take away from this is, it's not some newfangled thing that's going to sit off to the side of your health system and that you can do it in isolation. This is talking about your health system, be it at whatever scale, your local team, your local provider, or as a CHO or as an entire nation. It's about that health system developing the capabilities to learn from every patient who's treated. And as I said, the Institute of Medicine kind of drove this in the early days, and they came up with this definition of a learning health system, which was a health system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation. And then it talks about best practices being seamlessly embedded in the delivery process, and this whole thing being a byproduct of the delivery experience. So again, really featuring that it's about informatics, it's a little bit about IT, but it's also about quality improvement, it's about science, it's about incentives and culture, and all of those other things that we talk so much about in the QI community. And the second point to take out of it is that it's about being part of the system that exists as it exists at the moment. And there are lots of examples. These are just a few, and there are some links where you can follow up on these examples. But I'm not going to talk about them in detail, except to say that there's a vast diversity here. You know, there are learning health systems on all sorts of topics. So, you know, the one that I worked on mostly was at NHS Digital when I was living in England, and we were building a learning health system out of the national data collections, the national audits, and those sort of things. I visited Geisinger in the States, and they're an integrated provider covering, you know, about 2 million people in Pennsylvania, and they had created a learning health system within their provider organization as well. Then there are lots of learning health systems that are based around particular conditions, or that are based around particular treatments, or that are based around particular populations. And you can have learning health systems that that do any one of those particular things, depending on the needs. And you can find those examples and follow up from those links. But I suppose what the diversity tells you there is that there isn't going to be a blueprint that can be lifted and shifted. You're not going to find you know, a how-to guide that says this is exactly the steps you need to follow in order to develop a learning health system. And I think that's important to note, because that reflects the complexity within the health system and within the learning health system, and someone else's learning health system not necessarily going to be appropriate for you. It has to be co-designed between you and the stakeholders in your health system. But despite that, people like a guide, okay, and we published a couple of reports at Newcastle about learning health systems, and people kept coming back to us and saying, well, how do we do it? How do we do it? And we always said, well, it's not for us to say, that's for you to work out. And that's obviously not a very helpful response. So we got to thinking then about, can we have a framework of things that you need to think about when you're developing a learning health system, or when you're building a learning health system, or when you're trying to evaluate one? And we came up with this framework that I'm going to talk through briefly. And before I show you this and kind of scare everybody off, right, there's a lot of stuff on this framework. Most of it you're already doing. And I think the first thing I'd recommend anybody thinking about a learning health system to do is to go through this framework and tick off all the things that they're already doing. And I'd say you'll probably find, even starting from scratch, that you're doing 60 or 70% of it. But it'll help you to identify gaps and things that you could put into place that would cause a big improvement. Okay, so it looks a bit like this, right? And we produced this kind of wheel framework, and it was the only way that we could get it all onto one diagram, but nobody understood it without reading the 100-page report that went with it. So we kind of boiled that down to 4 key questions. Why do you want a learning health system? What are the technical building blocks that you're going to need? What complexity are you going to meet? And what strategic approaches to change are you going to need to take? And we can look very briefly at those now, but I would say that the report is linked at the end of the presentation, and there's like several chapters on each of these, so there's lots more information to be had. But the first and foremost, you need to know why you're doing it, okay? Because that's going to determine what it looks like. So, you know, for some people it's to improve outcomes or value, or to reduce unwarranted variation. Sometimes it's to generate knowledge. Sometimes it's to apply knowledge that's been generated elsewhere. Sometimes you've just spent a fortune on your electronic record system and you need to do something with it, so you need to utilize that investment. Sometimes it's to create a kind of health surveillance system, as we saw often during COVID. Sometimes it's to try and improve clinical performance. And sometimes for some organizations, it's a marketing exercise. and it sounds kind of good to have a learning health system. And you know, I can work with that too, because if it's a starting point to get in there, then that can be helpful. But okay, what are the technical building blocks within a learning health system? And I think there's an improvement cycle at the heart of every learning health system that really says you need to gather data from the practice that's taking place within your system. Then you need to generate knowledge from that data. And then perhaps most importantly, you need to apply that knowledge back into practice. And that's where the question about data saves lives comes from. And it's something that I've often spread and retweeted, hashtag data saves lives and all the rest. I think I've even got a t-shirt somewhere that says it on it. But the reality is data doesn't save lives, right? Strings of ones and zeros never saved anybody's life, right? What saves lives is knowledge applied at the front line, actionable knowledge. So you need this cycle to really bring about an improvement. Now, before you really get into that, you need to set up a learning community. And learning communities can take all shapes and sizes, but effectively what you want is a safe space where a group can come to reflect, where you can talk about mistakes freely, where there's trust and there's skills to do something about it, where you can create confidence and create an agency for change and be action focused, but also be sustainable. So it can't be a talking shop that runs out of steam after a couple of months. And you can have one or more learning communities, you know, and they really sit at the heart of any learning health system. So once you've got that, you're thinking about how do we get the data from practice. And if you've got an electronic system, then that can be great. There's lots of data that you can collect, but there can be an overload of data as well. You have to capture the data. You need standards for the data. You can't just collect all sorts of free text. You know, you need data quality. You need to make sure that the data actually reflects what's going on at the front line. You need to work out, well, where are we going to store it? How are we going to store it? And who's going to have access to it? What are the information governance and the data protection rules around that? And how are we going to share it? And do we know that it's going to mean the same thing to the people who we share it with as it does to us? And these are problems that you face if you have an electronic system, but they're also problems that you face if you've got a paper-based system. And we have a paper-based system here in Donegal, and I wish it was different, but you know, that's what we've got, but we can still capture data from practice and do something about it. Once we've got it, the data, we then need to generate knowledge. And there's the whole spectrum of ways to generate knowledge from data. So we can do RCTs. If we've got an electronic record system, we can embed randomized trials into the record system. We can do kind of quasi-experimental, retrospective observational studies on the data that we've collected. There's a whole range of newfangled AI and machine learning techniques that I don't really understand, but my co-author, Leora Horwitz, has written some stuff about in our report. And then you can learn a lot from local experience and capturing local experiences. There are approaches that we've borrowed from engineering, process mapping, and so on. And then it's important not to forget the qualitative methods as well, and the importance of capturing people's stories and people's experiences of care, and to make sense of that. And ultimately, one of the best ways of generating knowledge is through your learning community, bringing this data to the learning community and trying to get them to make sense of it. Can be a great way to generate knowledge. So it doesn't have to all be automated and done in a big artificial intelligence box. So once then you've got your knowledge, well, what do we do with it? So the traditional approach has been, well, we write a paper and then we spend 3 years trying to get it published. And then it gets published and somebody reads it or they don't read it. And maybe eventually 8 years after that, it gets into a guideline somewhere. Maybe somebody follows it, maybe they don't, right? A very slow process, absolutely essential, but very slow. So there are lots of new ways that we can look at to get that knowledge back into practice through, you know, behavior change techniques, through clinical decision support systems, through changes at the policy level, and through making knowledge computable as well, recording knowledge in a way that's interpretable by your machine, by your electronic record system or whatever system it happens to be. So there are lots of ways that you can do that. And then platforms can be really helpful, right? If you're sitting like I am here today in Donegal with an with a paper system, you know, you have to do everything from scratch. We're recording stuff from large case reviews, we're putting it into Excel sheets. That's really time consuming. If you've got a platform that already contains your data, it's much easier to manage that. Okay, so then the next question is about complexity. And what complexity are we going to face within this learning health system that we're building? It used to be that we would go through those technical building blocks and we'd build a system and then we'd try it out and then it wouldn't work. No one would use it, or it would produce results that were nonsense. And we wonder, well, why is this happening? And it's the same question that they came up with back in 2001 with crossing the quality chasm. Why do we got all this stuff? Why does it just not work? And it turns out really that it's to do with complexity, and too much uncontrolled complexity results in unpredictable outcomes and things generally not working. So we've incorporated into this framework for thinking about learning health systems Trish Greenhalgh from Oxford's NAS framework, and that's non-adoption, abandonment, scale-up, spread, and sustainability of health technology interventions. And this is just a way of understanding the complexity that is within your system. And we worked with Trish to kind of make this relevant to learning health systems. And what Trish says is that there's these 7 domains in which complexity exists. And the real message is if you've got too much complexity in too many of these domains, the thing is very likely to fail. Okay, so the 7 domains are here in this kind of wheel. The first one is the condition, you know, and if I'm thinking about CAMS, a lot of our conditions are really complex, socioeconomic determinants and comorbidities and all sorts of things that make them really complex. Some of them actually, though, not so complex. Some of them can actually be protocolized, you know, some sort of straightforward ADHD presentations and so on, you know, not as complex. So you need to think about the complexity of the condition. Then you need to think about the technologies that you're bringing to bear on this system. You know, are they straight out of the box technologies that are really mature and everyone knows how to use them and it's straightforward? If so, not so complex. If they need lots of integration and all that sort of stuff, then it's a big source for failure. Then you need to think about the value proposition of the system that you're building. So does it make sense for the people who are providing your technology to do it? Does it make sense for your organization to support it? And for everyone else involved in it, is there a value proposition? And if there isn't, things are quite likely to fail. The next domain that Trish points out is called the adopter system. And I don't like this. I think it's a very clinical way of talking about patients and their families and their carers and clinicians and people really. But this is really it. You know, the people who have to adopt your learning health system, are you making unrealistic expectations about them or their digital literacy or, you know, their time or their whatever it happens to be? Is that unrealistic? And if it is, they're not going to use it. And often you see with clinicians making, you know, threats to their professional identity and things like that will result in non-adoption of a system. The next one then is the organization, right? Is this a big kind of well-funded clinical academic center that's got a real history of innovation, or is this a real cash-strapped kind of provider that doesn't really have any history of innovation and all the rest of it? And that brings different complexities to it. And then there's the wider context, of course. So thinking, you know, about CAMS at the minute, you've probably seen we've had lots of really negative reports. There's lots of political involvement. There's lots of media involvement. There's lots of regulation that's stepping up to kind of try and get a grip on what's going on within CAMS, and all that will play in and have an effect on the learning health system, not to mention the funding and all the rest that might be available. And then once you've nailed down those 6 domains, it all changes over time. And so you need a system that's capable of changing over time. And that's the 7th domain. So you can see there the importance of complexity and how it really feeds into these sort of systems. And then once you understood the complexity, you know kind of what the building blocks are going to look like, you know why you want this thing, you really need to take a strategic view on how you bring about the changes required to do that. Okay, so the learning health system needs a strategy, or at least a strategic direction, and that needs to be aligned with the strategies of the organizations within which it's taking place. You need organizational structures to deliver that. You need a culture that's open to innovation and to change and to learning and to all of that, to feedback. You need a workforce that has the skills to deliver this and that is up for it. You need leadership to kind of drive that forward. You know, and sometimes this will involve very small changes within a team. Sometimes this will involve huge implementation projects. And you really need to take an implementation science view on doing that. Almost always it involves change in the behavior of, you know, people within your system, your patients and all the rest of it. And you need, again, to take a scientific approach to behavior change, an evidence-based approach to doing that. Perhaps most importantly, it needs to be co-designed, as I said, by all the participants in the system. And then, of course, you need to evaluate it. And that doesn't mean waiting 5 years and then do a massive evaluation. It means rapid cycle evaluation that drives that learning all the time. So there's some of the kind of key things to think about when you're developing a learning health system. And each of those, as I say, is expanded on the website into, several chapters. And also we're developing a toolkit which provides the tools for creating different aspects of that learning health system. But hopefully there'll be time for a bit of discussion now around some of those concepts. Thanks for listening.
Well, that's great, Tom. Thank you very much. It's a really great insight into the model and all of the different components. In your experience, both are in Ireland. Have you seen kind of good examples of where this even at smaller scales is in operation?
Yeah, I think so. And like I said in the middle there, people are doing a lot of this already, and you often find situations where people have never heard of a learning health system, but they kind of have a learning health system on their hands, or they have large components of it. I think every health system has a lot of those things to celebrate. If I think about our practice here, in CAMS and in Inishowen, we're a very small team, less than 10 staff. We've got a couple of hundred patients. We don't have an electronic record system. Doesn't sound like a very promising kind of place to build a learning health system, but actually there's a lot that we're doing. So we've implemented a kind of an online diagnostic questionnaire that goes out with referrals as soon as the referral is received and gives us a sort of a diagnostic indication. Then we've got sort of developing pathways of care and early interventions into those pathways. And we're now looking to procure an outcomes collection platform that we can start to understand the quality of our care, the outcomes, and how we can change that, and bringing slowly analytics into that and starting to collaborate with researchers and all the rest of it. So you can start to see, even on a tiny scale that we're operating here, starting to make those changes. And some of the things that are going on within the kind of quality improvement establishment that I've seen within Ireland would represent almost national scale learning health systems. And then there's everything in between. So I think even though people may not be calling them learning health systems, a lot of this is going on.
And I think what you're talking about there as well is building bits of it kind of at a time, and that you don't have to build the whole system on the first day, that you can kind of try different bits and try and link them up, maybe kind of with the framework in mind.
Well, I think that's really important because, you don't know what's going to work. That's the whole point of learning. You start somewhere with an idea, you bring together your learning community. You've probably got a learning community. You can judge it against those criteria. Is it safe? Is it open to errors and mistakes and all that sort of stuff? And you can maybe fine tune it. And then you can start to think immediately, what can we do to improve where we're at? And then you can measure it, and then you're into a kind of a quality improvement cycle. And it evolves over time, because with complexity, you can't really predict what's going to work. All you can do is respond as quickly as possible and do more of what works and less of what doesn't. And that's the way to do it. I don't think, first of all, you're never going to get the perfect learning health system, right? You're always going to be on that journey. And as you say, you have to start somewhere. So I think that's a really important point.
And how do you know you're learning? How do you know that the learning is happening? I mean, obviously, at some point, we'd like to see results or changes in performance, but are there kind of steps along the way that might indicate that we're doing some learning here?
Yeah, well, I mean, I think generally it's really important to measure outcomes of care, and you can do that through patient-reported outcomes or clinician-reported outcomes and whatever. And I think you can start to see patterns and changes in that. I think you can also gather evidence on experience, and I think it's really important to start capturing narrative, and qualitative descriptions of people's experience of working within the system, of being treated by the system, of having a friend or relative or whatever it happens to be treated within that system. And I think you bring all that together, and I think you can see progress happening. Can you see progress in the sort of KPIs that we're expected to, submit at the minute? I think that would be difficult. You might be able to see a waiting list coming down if that's what you focus your learning on, but I think you really need to go deeper than that to see the real progress, you know, and the things that really matter to patients.
Yeah, we talk a lot in quality improvement about stories and data, you know, and you know, neither on their own is sufficient, you know, but together they do a good job.
Absolutely.
I see a question there from Rob. Just curious as to what your experience with systems that are only focused on learning from when things go wrong. So that's obviously one focus of learning. But what are your thoughts on that?
Yeah. Yeah, no, I think that's a problem. You know, I think if we only learn from things that have gone wrong, then obviously something has to go wrong before you can learn. I mean, obviously you can measure your near misses and all, and there's no doubt that that's essential, right? That is essential learning. And it's often the type of learning that really has power to drive change because, you know, it makes people think about what has happened, you know, and it makes it real for people. But I think that can't be sufficient on its own. You know, I think you have to, you know, and we often don't know when things have gone wrong either, you know, because sometimes little things go wrong. A patient leaves unhappy, a patient has side effects from a treatment, or, you know, things like that. And we never know as clinicians. It doesn't come back to us, you know, so we need to be learning from those little experiences as well.
Yeah, and then the whole idea of learning from excellence as well, isn't there? Of just really trying to understand what, you know, why do things go right, and what are the things that make things go right. So yeah, there seems to be so many learning opportunities. You know, is it a case of just making yourself more open to them?
Yeah, well, I think it's about being more open to them, and I think that's a cultural issue, being open to learning, you know, but it's also about being able to learn from scenarios, you know, to have the infrastructure in place to learn, you know, because um, you know, a patient can come in here later this afternoon and have a really bad experience of their care with me, you know, and either I don't detect it because they don't tell me, or I detect it and I don't really understand why it happened, or, you know, I understand why it happened, but I'm too busy to do anything about it, or maybe I sort it out and it doesn't happen with me next time, but they come to somebody else and it happens again, you know. You need an infrastructure for, I suppose, for identifying the learning and then for scaling it and spreading it as well. And to your point, you know, learning from things that go well is really important. And what you often see within learning health systems is a real focus on what they call positive deviance.
Mm.
And it's because benchmarking sounds really scary, right? Because everybody thinks, oh, you're going to benchmark me against that team next door and show that I'm not doing as well. But when you turn that around and say, we're going to benchmark, but we're going to look at who's doing things really well, celebrate that, and see what we can all learn from it. What can be much more powerful and less threatening.
Great.
There's a lot of questions coming in the chat at the moment, Tom. I don't know how much time we have, but there's one here on just guidance on how to unite all parts of the system where sometimes improvement efforts are diluted. Perhaps if you've got QI, lean, change, transformation with all subtly different methodologies, but all improvement focused.
Yeah, I mean, that's really important. And I think what maybe I wasn't explicit about is that a learning health system is not an alternative to lean or to some other quality improvement approach. It requires there to be a quality improvement approach at its heart, you know, and it can be you know, it can be any of those that, you know, there's so many approaches within quality improvement, and really the learning health system concept is almost sits above that, and it's agnostic to which you use. And I think often when you drill down and look at the evidence, often they, you know, they often work as well as each other, you know, and there are questions about fidelity to those models and all of that stuff that needs to be addressed. But I think that sits at a level that's maybe within the learning health system concept, but isn't dictated by that. There's very little actually that's dictated by that framework that I showed you. It's just general concepts to think about. But I think it's a good start to be using one of those models that's been seen to work somewhere else, you know, and it gives you, because it can be really hard just to start from scratch and to kind of make up an improvement process. So, you know, it doesn't make sense to kind of reinvent the wheel. Does that answer that?
I think so,
Yeah.
and I think for a lot of people, they probably use multiple methodologies depending on what suits the particular challenge or issue that they're addressing, and it's trying to marry it all together then to get where you need to go. There's another interesting one here in terms of, as we're moving from more paper-based records to the electronic systems, is there a way to ensure that we build and design around a learning health system approach rather than retrospectively going back and trying to, retrofit things? Is there a way that we can have this in our heads as we start off this work?
Yeah, I think that's really, really important. And you see this so often in organizations that just kind of duplicate the paper notes in an electronic form and then realize that it's really all it does is just slow down their work and makes life harder. And really, there's a lot of evidence from the US about the levels of stress and burnout among clinicians who've implemented electronic record systems, and that's a real risk. You need to be thinking about your workflows within the organization where you're developing the electronic record system, and also thinking about how you might change if you had data. What data would you want? What data is useful and valuable to collect? When I was in England, we were spending, I think, within hospitals over £1 billion a year collecting data, and we were using very little of it, and it was heartbreaking, so I think really important to think about what data you need, but also what capabilities you need within your electronic record system to get that, not to, first of all, to generate the knowledge, to do the analytics, and then to get it back into practice. So, having a team of data analysts who are able to make sense of the data for you, and make sure that you're not coming up with, completely outrageous conclusions from the data that you've got. And also then, maybe to have clinical decision support systems built in so that you can actually then make that change back into practice as easily as possible, and you need to think about that up front, or else it's going to be really expensive and disruptive to retrofit it.
Yeah.
And from when we were talking before, Tom, I think we were, you could just get an electronic version of your paper records. That's sometimes the risk, and maybe that's, in one sense, that's one of the goals, but it really misses all the opportunities to build in learning at the same time. But there are decisions that are needed, like, in put funding aside, kind of to get that kind of aspect of the electronic records, or to then be able to capitalize on the what the data is telling you. So this does lead to big decisions, doesn't it?
It really does. And I mean, you see, I did a kind of workshop with a guy from the Mayo Clinic, and they'd implemented their record system, but then they'd done all sorts of stuff to build these platforms for data analytics, and platforms that made it possible for clinicians and managers and so on to go in and actually do useful analytics on the data. And they'd probably spent more on all of that stuff than they'd spend on the electronic record system. And the thing that people forget as well, that it costs money to have people typing all this stuff in, and it costs clinical time. So you need to be getting value for that. And I think if you just digitize your paper notes, I would almost say you'd be better not bothering doing it. Because I think you're going to lose a lot of productivity within your organization, and you're not going to gain an awful lot for it. So absolutely.
On that piece on sharing the learning, there's a point here from Barbara 7, just in terms of sharing the learning is so important, and how do you get it out there? And that probably ties into, what you're talking about there. If you don't have those luxury systems that, can just give you this beautiful dashboard of metrics in terms of where you're at, what are other ways to maybe get the data out there?
Yeah, well, so that's a massive question. In terms of getting the data out there, I guess if you're working in a kind of region, or even within a peer group, say, if it might be that you're looking at you're a community service, and you can, do some work locally and have a learning community among peers locally. Or it might be that you're looking at a particular condition, and you might have peers around the country, or you might even have peers around Europe or somewhere else. And you can join those sort of communities. There's a team led by a guy called Peter Margolis at Cincinnati Children's Hospital, and they've done some really interesting work where they started with setting up a learning community. I think they call it a learning network around inflammatory bowel disease, and they've recruited lots of international teams who are working on who are delivering the same service. And then they benchmark, and they do positive deviance stuff, and they do all sorts of quality improvement. They share best practice, and it's an absolutely fabulous model. And anyone then can join that model as long as they're prepared to share. Now, obviously, there's data protection stuff to do with all that. You need to aggregate it up and make sure that it wasn't identifiable. But there are things that you can do like that, and there are communities that already exist where you can do that, or you can create communities locally. That's in terms of sharing the data to kind of to learn. There's also a lot that you can do to share your methods also, so I know this group has been very involved with the Q community, and the Q community have lots of kind of sub-communities, subgroups talking about different things. You can set those up yourself. That's a fantastic community to be part of. So there's ways to share methods and so on there. And, there's a huge amount of research in this area as well that's available, but it's really hard to kind of make sense of it. And then I suppose there are models and methodologies that are well, recognized, like, and you talked about lean there earlier, and there are other ones that you can buy books about, or there are trainers who can come in and teach. So that's a huge question. You could write several books on that one. John probably has even more experience than me on trying to answer that question.
I suppose there's so many things here that are all integrated and linked together, aren't there? And it's trying to, get the value of that. I suppose the big challenge is people will tell you we're just too busy to put time aside for learning, and we've too many other things to be doing. How do we, and there's another question there I see, which is kind of, again, ideas like co-design, which is often seen as a slow process, but, if you go slow to go faster, or, to make something that actually will work or will last, how do we get kind of senior leaders on board? How do we get senior leaders into learning communities, to become part of those discussions, and really to see the value of these kind of communities?
Yeah, that's interesting. And, I would say we're too busy not to spend time learning, because if we spend all our time firefighting, the situation just gets worse and worse, I see it locally here. We get, we were at a point a while ago where we were getting more and more referrals. People were waiting on a long waiting list. People were becoming more unwell on the waiting list, so then it took longer to get them better. And then, we were more stretched, and we were offering them a lower intensity service. And eventually what we saw was that it's just getting bigger and bigger, So when we actually were able to spend a bit of time, and we were lucky that another team kind of helped us out as we were setting this team up, you can reverse that cycle, because you can start to work with your GPs, you can start to reduce the inappropriate referrals, then you can start to do a bit of preventative work, then you can bring in some early interventions, you can get people through the waiting list more quickly so they're not as unwell when you intervene, then they get better quicker. When they get better quicker, the caseload drops, then there's less inappropriate referrals, and overall you end up with a smaller caseload but much more intensive care for each patient. So it's only by spending time analysing those problems and putting time into it. How do you get senior leaders involved is a difficult one. And you look at what's happening in CAMS at the minute, and, shining a light on some of the issues that are there is one way to get senior leaders involved, because you can be sure there are plenty of senior leaders involved in CAMS at the moment. So while a learning health system might also ultimately help us to move away from kind of these big manual audits and inspections and all the rest of it, if that's the tools we've got at the moment, then we can use those, because ultimately things don't go wrong in services because, of the people on the ground. It's usually a systemic issue, that goes all the way up through governance into leadership. And, by identifying that, I think that will naturally bring leaders into it. The other way is to get them to spend loads of money or create a massive liability for them, and if they embark on an electronic record system, then, they're gonna want to know how you're spending that money, so they'll probably be involved. But there are lots of other ways. I guess it's a behavior change problem, isn't it? You can look at all the different ways to increase their motivation, their opportunity, and their capability to get involved. Capability, sometimes they may not actually have the skills to get involved in some of these debates. So, all three of those need to be addressed.
Great. Any more questions there, Juanita?
Yeah, no, just some really interesting questions, and there's some sort of a sharing of knowledge as well. I know Liz Cotter just come in there to say the Health Library Ireland has extensive subscriptions that can be embedded into the electronic health record system. So, checking out how the data could be accessed is something to think about as well. There is a piece here about the quantitative data. and that it often it makes up the majority of what's collected. And in terms of the qualitative data, have you come across any examples of services or areas using patient-reported outcome measures and patient-reported experience measures in a core, meaningful and effective way in a learning health system? So really,
Yeah,
so the patient-reported data, yeah, it's an interesting one.
yeah. So just the first, I'll come to the first one first, the Health Libraries Ireland. Now, I think that's really important, right? And I've just had a report that I wrote for Health Education England, published on basically looking at librarians and their role as central to the learning health system. And they absolutely are. And I didn't realize this, to my shame, until quite recently. But I suppose, you know, library services are in a transition phase from being the managers and custodians of physical libraries and books on shelves and collections and all the rest of it to being knowledge specialists and knowledge managers. And they can be central, not just in bringing the evidence into the system, but also in helping you organize the repositories for your data and your knowledge, and making that available to people within organizations. So if you have a librarian, get them involved. If you're building a learning health system, they'd be absolutely central. So your second point then about proms and experience, I think it's hard to think of a learning health system that doesn't take outcome measurement seriously. And, you know, most complex conditions, you know, you need to be getting patient-reported outcomes and patient-reported experience measures. I think it's be you know, very limited just to be relying on, you know, clinician-reported outcome measures. And I mean, we're using them here. So we've recently implemented a new ADHD pathway, and we are measuring outcome measures at every appointment and seeing how well the patient's going. And what the evidence shows on ADHD is really interesting, is that generally you think your patients are doing really well, and then you start measuring the outcomes and you realize they're not. And what happens is that you end up increasing the intensity of treatment, increasing dosages of medication and stuff, and actually optimizing their care when you start to be led by the outcomes. Because somebody comes in and says, yeah, you increase my medication, I'm much better now. And you write that down and then you leave it and you don't do any more about it. But when you look at the outcomes, you find a much more fine-grained issues that are going on in their life, and you realize that could be optimized even further. And at a higher level, I think when you come to the sort of things like positive deviance, benchmarking, and all the rest of it, you have to be using outcome measures. Looking at experience, I think that's really important as well. And there are lots of tools for kind of making sense of large numbers of people's experience and creating what have been called human sensor networks. So, you know, you're turning all of your staff or all of your patient population into effectively a sensor network that are feeding back their experience, like in a really manageable way. So you know, that would be how it could be used.
Great.
It's a very
Thank you,
exciting
Stephen.
time, isn't it? You know, and I suppose you know, the access, we all have computers, you know, that we carry around with us every day, and the ability to continuously, you know, if you have a chronic condition, or, you know, to continuously, you know, with relatively little effort, be able to kind of, you know, give that feedback, you know, for the whole system to learn. It is a remarkable kind of opportunity.
Yeah, I mean, there's lots of kind of uses emerging of, you know, wearables and sensors and things that your phone can pick up, and, you know, all the rest of it. But they haven't transformed health, you know, and you don't even see examples of services that have, because, you know, usually if it really worked, you would see somewhere that was doing it really well, and you'd think everybody needs to adopt this way. But, you know, so in some cases you do see really extraordinary things, and you see virtual wards and all that kind of thing. But it hasn't transformed healthcare in the way that maybe we thought it was, and it would. And I think that goes back to complexity. You know, all of those things are really complex, and you're making expectations of those patients and of the technology that's often overhyped. And, you know, even though we've got all of that technology, the focus, I think, has to be on the learning communities and the people within the system at the end of the day, you know, and I think that's where the change will really happen.
Yeah, that's great, Tom. Thank you so much. We've covered a lot of ground there, and I think it's interesting. It's a nice place to end, back to the learning community. I mean, I think that's one of my takeaways from today is if you really wanted to get serious about this, think about who, you know, and you said already, it probably is happening. Maybe it's informal, but who would you put into your learning community? Who is in there already? and maybe think about kind of formalizing that to some degree, you know, in terms of how you can build your own learning health system. So Tom, it's been a real pleasure. I've no doubt we will see you again, and people will be hearing more about you and your work in the years ahead, because it's so relevant. So thank you for joining us today.
It's been a pleasure.
Great. Just to kind of let people know about a few things. This is the Quality and Patient Safety Prospectus, just published at the beginning of the month, and lots of information about all the different education and learning programs that are available through the Quality and Patient Safety Directorate. And there's a QR code there if you want to learn more about that, or there's the link there at the bottom of the slide. And again, just to flag this up, this is coming soon. It's a human factors, introduction to human factors, one-day workshop for teams, and we'll share more information with you on that as it comes. There is already a HSE Land short video on that if you want to have a look at that. QPS network, Ireland network map. So again, we're really keen that people are on the map. If you're interested in quality and patient safety, if you're interested in learning health systems, get yourself on the map so you can sign up there and let us know who you are, and then it'll allow you to connect and find people who are in your region or maybe in the area that you're interested in. So again, encourage you to do that. And Tom mentioned earlier, again, you know, the Q community, which is across Ireland and Northern Ireland and the UK, you know, so again, connecting people interested in this work across the islands, but also, you know, loads of different resources there. The network itself is a huge resource, but there's also lots of other information that the Q community shares, and also the opportunity to be involved in kind of Q projects like research and some of the Q labs, which is looking at common problems that are shared across the health services. So if you want to contact Mary Lawless or Roisin Eglinton there, emails there, but we really would encourage you to check out Q and to join. Patient Safety Together, again, just to let you know about the website. This was launched recently. It brings together lots of different resources based around the patient safety strategy, including the National Patient Safety Alerts, safety supplements, safety stories. So certainly, I think if you have an interest in safety, but I think for anybody working in the health services, you'll probably find things there that are relevant to your work. So again, just check out the website. There is lots to find there. And then just to flag our next webinar in 2 weeks' time, where we're going to have a very we're going to try something new, something different. We're going to get people together really based around the prospectus and all the various educational opportunities that are there, but maybe give people time using some breakout rooms to maybe have a bit more interaction with members of the directorate to ask about the various educational offerings that are available. So we will be letting you know about this in the next couple of weeks, but I think that'll be something interesting and interactive. Just again to flag off our Twitter account there, so QPS TalkTime. If you follow us on that, and we'll kind of let you know about the webinars that are coming up, but also some of the other things that are related to the topics we talk about. And you can watch back on the previous webinars on the HSE National QPS Directorate YouTube channel. So again, check that out. There's an address there for that. And then finally, just please do let us know what your thoughts are on today's webinar by filling out the feedback. We will take those on board and we'll try and integrate them into our next episode. And you can contact Chris there if you have any ideas. And again, just to thank Chris and Juanita and Maureen and all the people who help out in making this webinar happen. Okay, well, folks, thank you very much. And Tom, thank you once more, and pleasure to see you. Bye-bye.